So we invite Sourabh Patwardhan. We all know Sourabh. He has the teachers of teachers. He's teaching by his videos to all of, not the youngster, but all of us. He has plenty of video. His YouTube channel also, which when I have any trouble in finding any solution, I go to his videos. So Sourabh is here luckily. So we have requested him to manage how to manage the floppy iris, diagnose early and manage early. His tips and tricks. Dr. Partha Vishwas is busy in court martials. He will join later on.
Okay. Good morning, everyone, and thank you, Dr. Mathur sir, for invitation for this particular talk. And can you give the audio also?
I'm Dr. Sourabh Patwardhan, and in this video, we'll be
Audio
speaking about intraoperative floppy iris syndrome or IFIS. So, what are the principles behind managing a floppy iris? The common causes for IFIS is alpha blockers, commonly tamsulosin, but there are many other drugs. Can we prevent IFIS? No, because even stopping the drug will not reverse its effect. Preoperative topical atropine and NSAIDs may be useful and inform the patient about possible problems and keep the pupil expanders ready. Most important risk factors for this iris prolapse is irrigation below the iris, wound leak, and fluid movement across the incision. Whenever that happens, this atonic iris tends to go and get incarcerated in the incisions. To prevent this, how we can do? We can keep the irrigation above the iris plane and keep the incisions very small and snugly fitting. Aspiration closer to the pupillar margin should be avoided so you do not pull the iris. In case of severe IFIS, where the pupil at the start itself is small, I think it's better to use a pupil expansion device or iris retractors, because the moment you start doing hydrodissection, like you can see here, the fluid pushes the iris through the incision. So as I did here, use pupil expanders so that the iris is retracted away from the central part and you can finish the surgery without damaging the iris further. But despite using iris retractors or pupil expansion devices, there is high chance that iris may still prolapse if you use high force or high fluidics in the anterior chamber. So always try to keep the fluidics slow, low, and also try to keep the incision where there is not much leak. Pupil expansion devices make these IFIS cases a bit simpler. Now, in case of mild to moderate IFIS, we can still go ahead without pupil expansion device. Always make the site incision very small so there is no leak. The main incision should have adequate length. If it is short, there is a high risk of iris prolapse. You can see the pupil is already dilated here. So keep it dilated. We should use heavy dispersive OVD, particularly Hylucoat, which not only protects endothelium but puts pressure on the peripheral iris. The initial dilated pupil can be achieved by using preoperative atropine and NSAIDs. You can also use intracameral adrenaline. Once we do a good size capsulorhexis, we have to perform very controlled hydrodissection. Idea here is not to have any fluid movement across the main incision. It has to be very low fluid used. When you enter your phaco probe, make sure that the irrigation is going on the sideways so that it's not pushing the iris up. Also, this initial period is a golden period where we can use slow flow. It's better to do a trench divide technique in these cases, in my opinion, because we are using low flow and you can divide the nucleus completely before the pupil starts coming down. This is a very important period. Now you can see that once we go to quadrant removal, because we have increased the flow rate, it also aspirates the OVD around, and then the pupil starts behaving and shows its true colors. So higher flow rate brings out the floppiness. High flow means more flow around the atonic iris and also the OVD gets washed away. So it's always better to keep the flow rate as low as possible to complete the step. Also, when you are using high flow maneuvers like in quadrant removal or doing chopping, you can catch the iris like this. So your chopper should be used to keep the pupillary margin or iris away from the aspiration port and avoid crossing the midline of the pupil to stay within the safe zone. And this is the better use of chopper where it's retracted away from the phaco tip where we want to aspirate out the nucleus. So always keep in mind that it's a atonic iris, and if you go closer, you use high flow rate, there is likelihood that you will damage this iris. Once you have finished the emulsification, you have to follow the probe withdrawal maneuver or ritual where you stop the irrigation, let some fluid come out from the side incision so that there is hypotony of the anterior chamber, and then you withdraw the phaco probe. This I call probe withdrawal ritual, and it helps in avoiding iris following the phaco probe and getting incarcerated. Same way, you have to follow probe insertion ritual where you stop the irrigation, you insert the probe in the anterior chamber, and then you start the irrigation. This helps because since your sleeve has already occluded the main incision, it avoids iris again getting trapped or incarcerated in the main incision. Now you can notice that there is absence of second instrument. So whenever not needed, you can just take out the second instrument. So it reduces the flow across that second instrument, and again iris incarceration is avoided. Whenever you need use of second instrument, just make sure that you keep tenting the incision up to avoid the outflow. Now bimanual IA or hybrid IA are also good alternatives where you can keep the irrigation flow above the iris level and reduce the iris incarceration. Intracameral adrenaline can also be used during the surgery to possibly add little bit of more tone and dilate the pupil. After you put the IL in the bag, make sure that both haptics have gone into the bag because many times at this stage the pupil comes down and you have to retract the iris to check that both the haptics are in the bag and the IL is properly positioned. You can see that the visco wash is done as routinely. My left hand is using the Sinsky to use to dial the IOL here, but you can see that the second instrument always keeps tenting up the incision to avoid the outflow from the side incision. If pupil is small at the beginning, it's better to use iris retractors or pupil expansion device that makes things easier. Now there are few tips I picked up from Dr. Nito Rosatelli, like using the chopper to perform under the iris inspection because there are chances in this small pupil that there might be some pieces which remain under the iris. So always examine them at the end. He injects usually carbachol or pilocarpine before IL implantation when he does hydroimplantation. That kind of constricts the pupil and reduces the chance of iris incarceration. So that can also be tried. When injecting IL, always place the cartridge tip first before starting the irrigation cannula because this avoids the iris getting incarcerated into the cartridge opening. So that's a great tip. And always carefully and slowly perform the stromal hydration without injecting the fluid inside the anterior chamber. So the anterior chamber pressure is maintained low while you are hydrating the incision and then fluid is pushed at the end. Thank you so much for listening.
Thank you, sir.
Thank you, Saurav. As always, very illustrative and informative video.